So we're going to go ahead tonight and begin our conversation. My name is Dr. Osman Raza. Pleasure to meet you all tonight. We have some wonderful guests here, and we want to welcome you to CDM's webinar for members and supporters on the discussion on the future of long-term care in Canada. So we're so thrilled to be hosting tonight's webinar on this topic regarding long-term care, given it's so top of mind for so many Canadians in the midst of COVID crisis that's been going on, but more importantly, including our panelists who have been sounding the alarm for years. And by way of introduction to CDM, we are a nationwide evidence-based, nonpartisan member organization dedicated to strengthening and preserving Canada's publicly funded healthcare system. Our mission is to provide a voice for Canadian doctors, residents, and medical students who want to strengthen and improve Canada's universal publicly funded healthcare system. We have three great panelists on tonight's webinar, so let's get started with a brief introduction of all three in no particular order. Dr. Pat Armstrong is a professor of sociology at York University and a fellow at the Royal Society of Canada. Focusing on equity in the fields of social policy, of women, work, and the health and social services, she has published widely. Currently, she is a principal investigator for a 10-year SSHRC funded project on reimagining long-term care and residential care, an international study of promising practices. She is also co-investigator on a number of studies looking into shifting division of labor in long-term care, residential care, late life issues faced by seniors, and a study comparing nursing home conditions working in Canada and the Nordic countries. Her fellow partner, Dr. Hugh Armstrong, is a distinguished research professor and professor emeritus of social work, political economy, and sociology at Carleton University in Ottawa. His areas of research include long-term care, the political economy of healthcare, and paid and unpaid work in healthcare. Along with Pat, he's a co-investigator of reimagining long-term residential care, which has spawned a number of related funded research projects in which he's equally involved. Pat and Hugh recently published their co-edited book, Privatization of Care, the Case of Nursing Home. As well, we have Dr. Amina Jabbar. She's a physician and specialist in geriatric medicine in the Greater Toronto Area. She's also the chair and board of directors at Progress Toronto. With the focus of populations that have been traditionally marginalized, Dr. Jabbar has facilitated anti-homophobic workshops in schools and community organizations with teens, education, and confronting homophobia, delivered sexual health services at Planned Parenthood, Toronto, and created tools of research and neighborhood-level health issues at the Center of Research on Inner City Health. She's currently pursuing her PhD in health policy at McMaster University and equally a proud member of CDM. So we'd like to begin tonight's webinar from hearing from the panelists regarding the state of long-term care in Canada, as well as some reasons why they believe the sector was so hard hit by COVID. Then we'll be followed up with a brief Q&A, and please feel free throughout the conversation to be adding your questions, and we will do our best to provide them to our panelists, after which our panelists will discuss ideas on how to change the course in long-term care in Canada and make sure the sector is better equipped for future challenges. That will be followed by a more lengthy Q&A, and we look forward to your questions and comments. And on that note, Pat and or Hughes, can either of you provide a brief sense of the current state of long-term care in Canada and how much is public, nonprofit, for-profit, and what is the staffing ratios?
We're delighted to be here. We'll try to keep our remarks brief because we would like questions and comments. We hope to keep learning. In terms of public, nonprofit, for-profit, I think the first thing to say is that we have to remind ourselves that Canada has at least 13 long-term care regimes, one for each province and territory. At about 60%, Ontario leads the way in for-profit terms. Another 22% or so are nonprofit, and the rest are owned and usually operated by municipalities. PEI, with only 19 homes in total, has 8 for-profits. So it ranks number 2, surprisingly. Alberta, not surprisingly, is next with 44% for-profit And Saskatchewan has the fewest at 6%, except for the territories, which have none. And it's not surprising that the for-profits want to be in the larger centers and the richer provinces because they want to make money. I can't be more precise, though, about the data because they are somewhat out of date and otherwise weak, especially for Quebec. And the for-profits are expanding. So the numbers I have are from 3 or 4 years ago. Another complication is that the for-profit category includes both small and often family-owned homes and the huge chains, such as Extendicare, Rivera, Chartwell, Sienna, Southbridge. These chains often combine long-term care or nursing homes with retirement homes and assorted other forms of congregate living. They try to blur as best they can. There is ample evidence, however, that for-profit homes tend to have worse outcomes in terms of such measures as mortality and hospitalization rates and verified complaints. They typically employ fewer staff, especially PSWs and healthcare aides. Families, meanwhile, when they have a choice, tend to avoid for-profit homes, preferring to wait longer for admission to nonprofit and public facilities. Pat.
It was faster than I thought. Before the pandemic began, in fact, long before, the World Health Organization, the International Labor Organization, the Organization for Economic Cooperation and Development were all warning about a crisis in labor in long-term residential care. As we like to say in our project, the conditions of work are the conditions of care. And I think all of us have become more aware of those conditions of work as the pandemic has gone on. The staffing levels that Osman mentioned are absolutely critical, of course, but they are an essential but not sufficient condition. And while, as is the case with ownership now, StatsCan doesn't do the same kind of data collection, it's harder to figure out what kind of staffing levels we currently have. But we do know that more than a decade ago, research in the United States said that you needed a minimum, an absolute minimum of 4 worked hours of nursing care, direct nursing care per resident per day. Few provinces have any minimums, and none of them set the minimum at that 4 hours, even though as I'm sure you all know, that the care needs of those people who are now in long-term care are way more complex and they're at much higher levels of need than when this 4 hours was set. In fact, Charlene Harrington, who's a US expert on this, has recently said we should be talking about more than 6 hours per resident per day. The data we have suggests it's around 3.6 in the big provinces in Canada. But as the BC advocate for seniors pointed out, these data aren't verified and they're not worked hours, they're paid hours. So virtually no resident in Canada is getting even the minimum of care that's required. As I said, there are other conditions beyond the staffing levels, although before I go there, one of the things I should say is there's lots of research showing the consequences of staffing levels. And most recent study out of California shows that in terms of infection rates, staffing levels was the critical indicator. So when we come to other conditions, we've learned a lot about those two during COVID, about the part-time work, the multiple job holding that takes people from job to job. We've heard less about training, and I think it's really important to understand the skilled nature of this work, and that the skills are required of the entire range of people who work in long-term care, which is another big central feature in our research. We argue that everybody who works in a home is a healthcare worker, and that includes dietary, laundry, and housekeeping. And we have to think of those staff people as skilled too, because of the nature of the needs of the people who are there. I want to mention two more things before I hand it back. One is supplies. We heard about in the military reports about supplies, excuse me, which are not just about PPEs, but also soaker pads and snacks, diapers, the whole range. And finally, there's the physical structure that we can talk about later.
So then, Dr. Jabbar, could you answer this one, and we'll give it back to the Armstrongs. Why do you believe the long-term care sector was hit so hard by COVID pandemic? And how could we have been better prepared or equipped?
It was, I think the media has done a relatively good job, I think, about at least covering what happened to the long-term care homes in the moment of COVID. And that was, I think, a really bad combination of what was the lived reality of residents in long-term care, who are, at least from like a geriatrician's point of view, from my point of view, these are people who are medically complex and often very frail. Staffing issues, which are already underlying staffing shortages. Pat has already referred specifically to people working across multiple sites. There's also a recent story that's come out finally that I'm glad has actually come to light around, for example, physicians having gone missing. Physicians who were the most responsible physicians for a lot of these residents who were not providing in-person care for a long time. So there were a host of staffing issues we're talking about. Equipment issues, so shortages of PPE, for example, and I think a lack of direction, I think, from the province, at least in Ontario in particular, where I think we ended up having per capita far more deaths. Quebec being fairly close behind, I understand as well. And this all happens on the background of, I think, chronic under-resourcing of the system. And I think the big thing that I do think gets lost in the media is there's a fundamental presence of for-profit operators, which means money that would have otherwise gone towards the care of individuals during a pandemic was probably being siphoned off into a corporation. And again, I think I will underscore that's really challenging, I think, given the financials, to kind of figure out exactly how much gets taken in by private for-profit operators. And that's especially challenging, particularly during COVID, because it's been really hard to figure out where people are investing or not investing their money. Pat and Hugh, turn it over to you and what you've seen as well.
Well, one of the problems for long-term care is the focus was on hospitals to start with, and the long-term care homes were ignored. Another issue is the whole inspections that certainly in our province of Ontario, the inspections were suspended during COVID, but they had been dramatically cut back before. And for the most part, homes were warned when an inspector was coming. And so we were told by staff, for instance, that they staffed up when they knew an inspection was coming. So it created a very different atmosphere for when the very few inspectors that did come arrived. But there's also an enforcement issue in terms of the existing regulations, because not much happens over the long term to those that are found to not be in compliance. There's some reporting goes on, but certainly in Ontario, a number of the homes that had the worst outbreaks also had the worst compliance with the regulations that exist. The other thing I wanted to say is about the regulations themselves. We have a paper we call It Is a Scandal, in which we looked at the 6 countries in our research project in terms of when there was a scandal about a long-term care home and what happened as a result. So as Amina was saying, most of those scandals were in for-profit, corporate-owned homes. And except in Norway and Sweden, the response was more regulation. Norway and Sweden actually went after the ownership question when this happened, and did introduce some regulations related to ownership. In the US and Canada, we introduced more regulations, and we were repeatedly told that long-term care is more regulated than the nuclear industry. in the US. But the regulations seem to be the regulations of the worker or the resident as opposed to the ownership and issues like staffing levels. So we have rules that at what time you have to go to, everybody has to be at breakfast, but not how many people have to be there helping them have breakfast. And so we really need to look at those regulations, those inspections, making sure that there's compliance and that there are consequences when you don't comply. And that's what's taken us to where we are now, I think.
I'll pick up on that. The responses by governments, and I know most about Ontario, these responses have lacked clarity and consistency, with one exception that's already been mentioned, which is that priority has been assigned to hospitals. Long-term care facilities have been kept relatively invisible, except when there is a big breakout with lots of deaths, and there certainly have been lots of deaths. About 75% of the deaths in Canada, COVID deaths, have occurred in and around long-term care facilities. The hospitals are better prepared to meet anticipated surges, and they certainly make their views known to government on a regular basis on that score. They are better equipped in terms of PPE and other IPACs, other inspection, prevention, and control mechanisms. They have more experts. They're sometimes called upon to send some of their experts to the long-term care facilities, either to help or to direct those facilities. Sometimes governments do it, sometimes the long-term care facilities do it on their own, and sometimes the hospital refuse to offer help. Only BC and Quebec appear to have addressed at all the severe staffing shortages. Ontario certainly has not, despite repeated warnings both before and during the pandemic. Instead, what we get is bluster from Premier Ford and waffling from his chief medical officer. Meanwhile, and this has just come out in the very last few days, long-term care outbreaks have returned with a vengeance, notably at 2 Extendicare facilities in Ottawa. Another preparatory device was the appointment of Jane Philpott to manage data, which has been a long-standing problem. The Ontario Health Data Platform, which was announced with great fanfare in the spring, but is still in the early stages of being developed and will be available really only to researchers. It will entail a slight extension of what ICES now does with administrative data from hospitals. But we can't hold out the hope that it will provide a lot of good new data for all of us, especially those of us who are not deeply entwined in the system. We know that the system will get better when there's a lot of public pressure for it to become better, just as was the case 50 or 60 years ago with Medicare. But there are no plans that I know of to make more data more quickly, more consistently, more readily available to all of us. Thank you.
Thank you so much for this insight. We'd like to open it up to some questions. So I see there have been a couple in the chat, so we'll start there. Feel free to continue to add questions in the chat box. If you'd like to ask live, you can click the raise hand button, and I'll unmute participants and name them and ask them to ask their question. The first question we have is from Barb, and she says, considering the Canadian taxpayer spent a lot of money sending in the army and extra help to clean up the messes in for-profit care and protect seniors from COVID, is there a way the government can send the bill for the cleanup to the private operators? She says she sees that it could be challenged in court, but that it could be an opportunity to showcase how much they profited at the expense of seniors and their families.
Can I say something on that, Katie?
Yeah.
The speech from the throne today, interestingly enough, says that they are going to change the criminal code to hold homes criminally responsible for not providing sufficient and appropriate care, which I think is an interesting development. I think that question about charging them for those services is a very important one. I kept asking about why are we topping up the wages of people in this sector? Why don't we make the employers pay in those sectors that have those very low wages?
And what they do is with great regularity, claim that they don't have enough money as it is, and they certainly can't give any money back to the government or to the military. Meanwhile, of course, they have very substantial profit margins that at least the companies that operate using the stock market have to reveal each year. So they're making lots of money. And they wouldn't be doing it if they weren't making lots of money.
Absolutely. I mean, one of the things that I think the question that you just asked gets to the heart of is this issue around accountability within the system, and particularly around COVID. I will say, so my practice is based out of Trillium Health Partners in Mississauga in Ontario. And I was actually 34 weeks pregnant at the time when many of the outbreaks happened. So fortunately, my colleagues told me not to come in. But the stories I was hearing from them, particularly the ones who had gone into 2 of the long-term care facilities who were ultimately taken over by the military, were atrocious. Things around, I mean, I think people have read the military report or have seen the military report, but they are purely abusive and negligent. So I think there are definitely, I think, class action lawsuit in Ontario that is in motion. Trillium Health Partners has been involved in a police investigation now that's been taking place, specifically looking at abuse and negligence at Camilla. And so I think at least there are small bits of accountability that are happening, but I hope that in the larger scheme of things, we don't lose sight of how we got here in the first place. And I think that's my big fear around the double-edged sword that is COVID. While I am so grateful that there is finally a focus on long-term care, particularly for me, where so many of my patients live, my fear is that as quickly as we deal with what happens in COVID and long-term care, that's how quick we'll forget about dealing with issues that are underlying around profit and private interests around long-term care.
We can't let a crisis go to waste, so we have to keep up the pressure as best we can. Meanwhile, again, in Ontario, the government quietly passed a law 18 months ago limiting Crown liability, and more recently, it tightened the criteria under which you could sue an operator. So there are a number of lawsuits, at least 20 that I know of, going ahead
In Ontario.
In Ontario. Whether they will succeed, I don't know. I think, again, public opinion is going to be crucial.
We have another question asking, and I've heard a lot of things and questions about data in general throughout the pandemic. But the question is there a disproportionate impact of COVID-19 on racialized communities within long-term care homes?
But it's interesting. We were talking to Jane Philpott the other day about the new data collection, and she said that they're going to try and get those data. So I don't think that they're available.
I don't think they are. I mean, it's interesting. You were going to say, Pat?
No, go ahead. You were.
The only other thing I was going to say is, I mean, I'm very familiar with the MDS-RI data. And what's interesting is the MDS-RI data and the surveys collect race, ethnicity data in the States. I should say for people who are unfamiliar with MDS-RI, it is a very medicalized questionnaire, but it is a questionnaire that is asked of everybody in home care in Ontario and every long-term care facility in Ontario, and I believe most of Canada, and it's also international. So it's an American questionnaire, and it is fairly, as I mentioned, fairly medicalized is the way I would describe it. I'm fairly familiar with that questionnaire specifically because I work with big data as part of my PhD. And so what's interesting, again, as I've mentioned with that questionnaire is that questionnaire does have a race question in the US. But for some reason, and I haven't been able to get to the bottom of it yet, that race question was removed when it was implemented in Canada. So I haven't quite gotten an answer yet about why, but if I do, I will let people know.
It seems to me this is another example, to take the Ontario case, of provincial government bluster, but not much action. In response to Black Lives Matter, there has been a move, not only in terms of nursing homes, but also in terms of police and others, to start collecting the data, but only to start in the last few weeks. And they haven't got very far. Certainly, as you point out, nowhere in terms of RI-MDS, but nowhere in other ways as well. What we do know is that the workers in nursing homes are twice as likely, roughly twice as likely to be persons of color than is true of the general population. So if they are more at risk from COVID-19, it won't be a big surprise that it will be persons of color who will be more at risk than others.
Ms. Mathewson, you had a question, I believe.
Yeah, I'm very interested. I'm from BC, and we've tried to address this problem even before COVID was evident in our area. We have our seniors advocate. Even the private care homes here have to be licensed by a health region. And we have 5 in the province. Some of them are more ethnically situated, like our Fraser Health region. One of the things we have at the hospital, and I've been retired for 15 years and I've become what is called a patient advocate. So I go to a lot of these care homes and inspect them for what is available, staff numbers, etc. And I've been doing that for the last 10 years. We still have 80% of our residents in care homes have come down with COVID. And I think one of the things you said was the problem is because the workers in these areas are from different parts of the world and more susceptible to the virus. But even with all the care that we put in to try to combat these problems, we still have the problems, and it's because of the staff being what they're being paid, and because of that they have to work in more than one region, and the number of staff in the care home. So I mean, we've tried in our province to address this problem over the last 5, 6, 10 years, and we've still run into a problem. So one of the things I see is the fact that health is under the federal finance, but provincial regulations. So our province is different from all the others, and we're looking at trying to get national care set up for seniors, a seniors' rights advocate. And I was wondering what the panelists thought about getting more of a national input from all the provinces on what is needed in each province and how to make it nationally accepted.
Well, that's promised in the throne speech today, just by the way, that they're going to talk to all the provinces and territories about introducing national standards. I'm a little leery. I think back to the introduction of the Canada Health Act when BC, Ontario, and Quebec said they weren't going to be part until the government said, that's fine. Then you don't get the money. So I think leadership's going to have to come from the top. I think that the susceptibility of different people to COVID in terms of working in long-term care is very much related to their working conditions. And the latest Canadian Institute for Health Information data on the pandemic said that our staffing levels were half as high as the Netherlands and Norway. And so that would be a very good starting point, but it also has to include their wages. It has to include their benefits, has to include their right to unionization. It has to include their training that needs to be paid for. Because the other thing I would argue, and I was going to say this later, but I'll say it now, is that the gender composition of those who work in long-term care, 90% of the care aides, or I think in BC they're called care aides, right? We call them personal support workers in Ontario. 90% of them across the country are women. And we tend to assume that this is work that any woman can do by virtue of being a woman. And we have to really start recognizing that it's skilled work, and that it's skilled work that deserves to be adequately compensated and protected.
We, with others, did a survey about 15 years ago, comparing on 3 Canadian provinces with Norway, Sweden, Finland. And the incidence of violence against staff, PSWs, PSAs, whatever they're called in different places, was about 7 times as much, almost 7 times as much in Canada as in the other countries on a daily or almost daily basis. And that was despite the fact that we posed the question somewhat differently. In Canada, the question had to do with whether you were in fact subject to violence. And in the Nordic countries, it also included whether there was a threat that you might be. So the 7-to-1, daily or almost daily, was in fact an understatement of the difference. And the difference did not have to do with the characteristics of the resident population. They were pretty much the same. The difference had to do with how much time the workers had, and so whether they were short-staffed or not, whether they had enough staff. It had to do with their autonomy, whether they had to simply move quickly from task to task, or whether they could spend some time with individual residents getting to know them, or groups of residents, and had to do with their training, all the things that Pat has talked about. We have only those things by association, not directly by cause, but it seems to us pretty clear that if you are having to rush to toilet somebody or feed somebody or get them to breakfast for the 8 o'clock, then you're not going to get to know the resident very well, and there will be some anxiety and even hostility on both sides. When we were in the Scandinavian countries, the units were smaller. The people who do what we call the PSW work were also the ones to prepare the breakfast for the residents when they chose to get up. So a very different set of relationships, a very different type of care in the Nordic countries than in Canada.
So on that note, and you've briefly mentioned it, how do you guys believe that we should change the course and make improvements for long-term care in Canada? It has been mentioned, as you said in the throne speech, but what should we do better to incorporate long-term care in the public healthcare system? And is there a consideration for altogether ban for profit delivery? What type of regulations do you guys believe are required?
You're on national strategy.
I'm actually kind of curious, Pat and Hugh, about what you will say about what I'm about to say, and particularly because I've been thinking about it for the last, I think, a few weeks as well. And you've been doing this for years, so it's nice to know what you think.
You're old, what can I say?
It's a lot of wisdom I need to just absorb from people right now. What's, my ultimate dream, what I would love to see is to see long-term care, and I will say home care, both of those services eventually fall within Medicare, right? I mean, that is what I would want to see. And the reason I say that very specifically, and I'll tell you why I think about both of them at the same time. And I've said this to people as well. I find it so odd that we live in a country where the resources that some people may need as they age, particularly again very often from a resource and a medical perspective, we see that through a lens of personal responsibility rather than something that we need to provide collectively. And I don't know why we do that, in particular, especially since we, as a Canadian society, seem to love and glorify Medicare as something that's deep to our national identity. And so I think, as we move forward, I do want to start thinking more pragmatically about how we do that. I feel very strongly at this point, I think, based on sort of the things that I've been looking at, that I think if we are to have Medicare eventually cover long-term care, that it absolutely also has to cover home care. And I'll tell you why specifically I've sort of come to this feeling at this point, although I'm always open to being talked out of this position. I've seen many residents end up in long-term care, not necessarily because they...
Oh, you've gone.
There you go. I'm back. I've seen residents end up in long-term care specifically because they don't have any other supports or resources. So for example, I can think of a patient I can remember before I went on mat leave, who had dementia, who had diabetes, and she was going to need to go into long-term care specifically because she needed the insulin. There was no other regimen we could come up with, but she was alone and she had no family and she was on OAS only. She had very few resources. And we couldn't figure out from a home care perspective how she could make sure she was getting her insulin and how she could get it safely. This was a person who could have been very easily, I think, cared for at home, but because of the lack of resources, I think, in home care, and because of the lack of flexibility in home care, we had forced her into long-term care. And so I think about that particular person often because it is such a tangible example, but also because I think I had started digging a little bit in some of the research, and it does suggest, at least in Canada, we probably have at least 20% of people in long-term care who are there because of that lack of resources, which is so interesting to me because that means to me, and I don't exactly know if this would be the case, but I wonder if those 20% of people are also people who would much rather be at home, but just don't have the money for the PSW or for the extra services or for whatever else they need in order to stay there.
Whew. Well, I'd like to go into several directions on this. Emmett Hall, when he did his famous Royal Commission report, said you should cover the whole range. You should have a system that covers the whole range. And so, yes, that makes sense. Do I think that it would help to put it under the Canada Health Act? The answer is no, but that's getting me into more and more trouble these days, but I can talk about that later. But and definitely there's a very important relationship between home care and long-term care. We've been arguing for a long time that it should be a positive option because, not every home is a haven in a heartless world. Not everybody has a home. And in many cases, what being at home means is exhaustion for the other person who is there. And it makes me think of, we did a study last year for the city of Toronto, which took us in. The City of Toronto owns 10 homes, and we were into to most of those homes. And in one of them, which was not the nicest by far of the homes we've been in, and we were speaking to the Residents' Council that are required by law in this province. And we said, is there anything better about being here than there is and being at home? And they said unanimously, yes. And one of the things they said is we have company. And they said, it's not always the case that we like them all, but if I was at home, I'd be all alone. The other thing they said was that they felt safe. Actually, your example fits right into that. You know, one woman talked about having had a stroke and she couldn't remember to take her insulin. She was diabetic, and obviously. And the third thing they said was that we have activities. If I was home, lots of people say we spend most of our time watching TV. They said, that's all I do at home. Here I get to do some other things. So I think we at least have to think about congregate supportive living in various ways. In terms of, I certainly feel that there should be a national presence in home and long-term care, and that they should be connected. And if people want me to talk about why I think that the Canada Health Act isn't the place to start, I will, but instead I would say that we need to focus first and foremost and very quickly on a labor force strategy. And that labor force strategy can include long-term or home care for sure. And PSWs, that's what they call them in the throne speech. But those kinds, they said that they're going to take special action in terms of people who do that kind of basic care, which I think could be really important. But we need a national strategy that I think is based on recognizing that care is a relationship, that recognizes that this is skilled work and the skills are specific to looking after these populations, that it requires the skills we were talking about earlier in terms of having to, in Canada, especially in our large cities, being able to provide culturally appropriate care. The other thing I would say is that our national labor force strategy has to include the entire range of services. Let's recognize the determinants of health and recognize that food is as critical in care as many of the other things we think of as necessary. It's not just about nutrition, it's also about the social and about a whole lot of things, but I'll get off that soapbox and see what he has to say.
I think we have to also remember that the people who are in nursing homes are, by different estimates, between 60 and 80% cognitively impaired, most with dementia. Some can and do operate quite well with the degree of dementia that they have, but it is difficult in many instances for them to live alone at home under that condition. The age at entry average age at entry is now approaching 85 years. So we're not talking about spry 60-year-olds who would prefer to be at home. The other thing is that if they are at home, who's going to provide them with care? It's almost certainly going to be a woman. It's almost certainly going to be someone who is not paid. Yes, we should improve. Or trained. Yeah, we should certainly improve home care and make it a more viable option for more people. But we can't forget that we need a great deal more long-term care. In Ontario, the waiting list is now about 38,000 people. And they have already been assessed by the local LIN, or whatever it's now called, as being in need of long-term care, of admission to a home care facility, to a nursing home facility. the criteria are becoming more stringent by the year. So we're not looking in very many cases at people who could do well in a private home. In some cases, yes, but not very many. So let's focus on, as Pat says, a labor force strategy. Let's focus on getting profits out of both nursing homes and home care, often the same companies. And let's figure out how we're going to provide more dignity, more joy in nursing homes.
And that, I don't think that's inconsistent with what you're saying, Amina, at all.
No, I think one of the things that I really am starting to take away is, I think certainly in Ontario, my impression is that we think of long-term care as a last resort.
Yeah.
And in doing so, we've warehoused older people.
Yeah.
It shouldn't be, though.
And it shouldn't be. And I think there should be, people should have the option if that they need. I think you're right. There's something about having, there's joy in community. And people should not be robbed of that in the sunset of their life.
Well, and the number of families we've interviewed, and especially women who say, I had to put my mother in a home, you know, they feel like they've totally failed, but, you know, they say, I just can't do it anymore. You know, they're exhausted, they're wiped. Yeah, you know, it's seen as the last and worst resort.
Right. And I think
my friends all say, I'm not going in one of those places.
Yeah. Or the reaction of being, well, if things are so bad, maybe we should take them out.
Yeah.
Right.
Yeah.
And it's not a feasible option for people always.
Yeah, that's what Andre Picard was suggesting back in April, and he quickly was brought to heel because it was pointed out to him that there is no place for a lot of those people to go.
I worked in complex continuing care, which is the hospital type heaviest level of care. And very often, I'm a social worker and also capacity assessor. And what I noticed was there was a great deal of guilt placed upon family caregivers, like we promised dad that we'd never put mother in a home. And they go to great sacrifice and expense to keep mother at home. And then when she came, because of care needs, into complex continuing care, she would brighten up and join in everything. And the families would say, well, it was such a mistake because the supportive one-on-one thing at home, the trouble was the social isolation.
Yeah.
And this related very much to the very quick diagnosis of dementia given to people who either are poor or have no family support. And then when they get in a more supportive setting, they brighten up and join in, and dementia is compounded by social isolation. And also there's the whole question, not just, I agree with Amina about the importance of race-based data, but I worked for 10 years in downtown Toronto as a capacity assessor. And I was dealing with people who were poor and B, socially isolated with no family support. And without exception, somebody had said they were demented, right? And so I think that we need to look at the whole business of the relationship between dementia and social isolation, whether it's at home with a family caregiver or a hired caregiver, or whether it's with some home care. So I feel very strongly about this. And I do agree, Amina, about the business of, I'm 84 myself, and I have congestive heart failure. So I'm in a lot of different categories, and so I'm not practicing. I'm just presenting my experience in the last 10 years as a capacity assessor in downtown Toronto. And I would be administering the Substitute Decisions Act. And when every time I look at the record, demented, 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 but when you actually looked at the holistic picture, the poverty and the social isolation and the lack of family support, that was equally important. You know, and I think also we have to look at the fact that people 85 plus is the fastest growing group of elders. You know, when I worked at Sunnybrook, you got a letter from the Queen if you turned 100. I went to a very fancy retirement home to do a cross-border assessment, and the director of nursing there said that they had just had a special birthday party for the 6 residents who had turned 100 in the last month. So I think this is data. We're collecting the wrong kind of data. And I agree with Amina, we're assigning home care and long-term care as personal responsibility rather than a healthcare intervention. So I agree also about the auspices of the long-term care. I mean, you're spot on about that. But the fact is, we need to be considering across a range of care needs, and also how this particular highly vulnerable group of elders, a lot of the factors are poverty and premature diagnosis of dementia and lack of family support.
So mindful of time, we would just like to ask the panelists for their closing remarks.
Yes.
In a brevity stance, given I'm well aware that 9 o'clock is fast approaching. So if you guys could give any closing remarks, please.
I will say that I'm very grateful that CDM made space and time to bring this up. I mean, it's clearly evident from the fact that I don't think we even touched on half the questions that showed up in the comment box, how important of an issue that this is. So I will just say, again, I'm hats off to CDM for, I think, recognizing the importance of actually focusing on this. And I hope this is the beginning of many conversations to have.
I'd say ditto. And I also think that we are really concerned for very obvious and important reasons with safety, but we can't forget about joy.
I'm going to preach to the choir for a minute. We have to get rid of profit taking from long-term care and home care, but it's not going to be easy. The big chains in particular have got into it for reasons having to do with real estate, REITs, to take the Rivera case. But there are some things we can do right away, it seems to me. We should insist that governments authorize no new long-term care builds that are for profit.
Yes.
They should immediately establish firm and enforced requirements for appropriate staffing levels and accurate reporting. Homes should cancel the contracts they have with food and laundry and maintenance and cleaning services from outside, even management services from outside, as soon as the current contract is over. And we should get rid of contracts with nursing agencies and instead offer regular employment, usually full-time, to nurses, PSWs, et cetera. Those are things we can do relatively quickly as we try to get rid of the for-profit chains and their land holdings.
And on that note, thank you everyone for joining tonight for such an engaging conversation. For questions we weren't able to answer, we'll be hoping to follow up with answers via email and providing a recording of the webinar. And most importantly, thank you to our panelists, not only for participating in tonight's webinar, but also for the work that you all do. For those who are physicians, retired, practicing residents, or medical students who have already renewed your membership with CDM for 2020, thank you very much. If any of you have any questions regarding membership and how to renew, please do reach out to myself or Katie after the webinar, and you can provide an email in the chat box and we're happy to reach out to you. CDM will be having our AGM later this fall, so please feel free to renew your memberships to be able to participate. But most importantly, we wish you all a wonderful evening and hope you have a good night. Take care.
Thank you.
Thank you.
Thank you so much, everyone.